Hey everyone, sorry. So I apologize for the delay in getting some of these guides out to you. By now, you guys are all experts in HCS, so you don't even need them. So this is just for the new hires, okay? Wanted to go through a couple of things. I am seeing a really big improvement. So November 1, yesterday, we moved to 100% chart audit. So between myself and all the other nursing leaders and department leaders, we're going to be looking at all of the charts to make sure that we're getting it right. Joint Commission, if you haven't heard it, we go into our window in March. We're thinking they're going to come early. They also, if you're aware about this, they've also combined with CMS. So they're doing group joint surveys, which means that we can have anywhere from 4 to 15 people on site for a week, inspecting and looking in all of our closets and under the beds and all that other stuff. So we really have a small window, holidays are coming up, to really kind of get all this stuff taken care of. So a couple of things I wanted to review with you guys because not everybody is aware. On the adolescent unit, I am getting consent for all of the adolescents, but you do have to fill out the rec. I had a nurse yesterday tell me she didn't know what I was really talking about. She hadn't been trained. Okay, no big deal. That's what we're here for. So on cottage A and B, I'm sorry, I went too fast. If you work on the adolescent unit and your patient is a DFACS child, we have to get consent for meds. You can medicate them when they get here, but you have to, you can medicate them when they get here, but you still have to fill out the form, send it to me as soon as possible. Obviously I work 24/7, so I'll send it to DFACS. I usually get them back within about 4 hours. If it's the weekend, I won't get them back until Monday, but you can still medicate the child, okay? We're not waiting on them to send that form because of their medications the patient was already on. So A and B both have similar folders. If you go here to DFAC consents, you wanna go ahead and open that up. There's a blank one right here. Click on that. You can, if you type, if you write, whatever is easier, it already has my information here. It already has a doctor information. What you would be filling in is the name of the child, the date of birth, doctor, if it's the right doctor. And then you want to continue current medication. They're new admissions. If they want to add something, you can click that and we want to add something new. Okay. Please be mindful of what you check because this is 99% of the time why they send them back to me. Okay. You can write in, type in your meds here, and then you put in, anything new goes here. I do recommend that you put a dosage range. This way we're not sending forms 24/7 as doctors increase meds. Melatonin, let's say Benadryl, if the patient's ordered Abilify and they want to do Abilify 2 milligrams, go ahead and do the range for 2 to 10 milligrams. That way if Dr. K says, you know what, we're going to do 5 milligrams now, we already have consent. One less thing we got to do, all right? At the end, you can type in the signature. When you print this out, you can go ahead and sign your name. So I would write Amy Harshaw on here, and then you will scan it or email it to me. There is my email as well as med consents are both saved on the printers on A and B. So A Harshaw and DFACS, these both two are already saved, okay? So hit scan, save it, that's it. You can keep the form, you can shred it. Once I get it, I send it to DFACS. When I get it back, I keep a copy of it, so don't worry about that. And I also upload it into HCS. So let me show you how you access that. So when you go to the table of contents, you can find everything you possibly need for our patients in here, okay? Dig in there, you can find it. If you type in DFACS, look at that, DFACS consent scanned. Click on that, and here you'll see something that says view document. If you click on it to open it, you will see the consent that has been signed that I have uploaded, okay? Obviously right now it's empty because this is a real patient, but you will see that. So I will put it up here under DFACS consent. I will also go under consent and add all the changes there too, okay? So you don't have to worry about that, but I really need you guys to make sure that you're starting the medications and that you are sending them to me as soon as possible so we can get the kids taken care of, okay? Really, the only thing I had about consents, you guys have been playing in the system now for about, I don't know, 3 months. So I know that you guys are really familiar with making sure that we get consent. We don't want to see this button red. We want to make sure that it's gray. So making sure you're adding consents for new admissions as needed. I don't have any meds for this patient. The other piece that I wanted to go over with you guys was sending the patient to the hospital. and seclusion and restraint. So as we have completely, you know, we've got it A and B, we threw away a bunch of stuff on F, we're gonna hit C and E next, and we're gonna keep doing that. We wanna get rid of paper, it's old, it's antiquated, we're getting into the new. So a couple of things that you guys really need to make sure you're doing on HCS. So the first thing I'm gonna show you is ER send out. Something happens, my patient fell, right? Let's say this cottage F. You wanna add your order. So you wanna do a transfer order. I'm sorry. Oh, so we should have an order to send the patient to the hospital under miscellaneous, I guess is what we can use. So I apologize for not being more prepared for that. So you can use, that's fine, miscellaneous order, unscheduled. You know, the doctor gives you the order. What is the order? The order send patient to ER, you know, related to altered, oh no, we said he fell, so related to a fall. Okay, and then I hit OK, and it is here somewhere. There it is, send patient to ER related to fall. So now I have my order in there. Okay, so now what you're gonna want to do here, and again, you can look, you could also type in key phrases, and it'll pull up what we need. So transfer will pull up a memo to a transfer hospital to hospital, memorandum to transfer hospital to hospital, transfer. So you want to click that, and we're going to hit add. This is my note. So my patient is a male. Yes, I'm going to say I'm going to notify, you know, their spouse. Receiving facility is going to be Wellstar Kennestone. Report given to a charge RN. Maybe you know their name. Facility staff member, I don't know. I'm going to say Pat. You know, maybe that's, oh, I'm sorry. So that one's our name. So this one's our name. So this is hit or miss, but I'm just going to put my name in there. I am working with them, thanks to one of the nurses on F, this issue. So I am working with them to try to get rid of that. So I gave report to, you know, the charge RN. His name is Pat. Presenting problem. Patient had a fall on unit. Unsure if, you know, head was injured. Complaining of pain. All right. And then this will pull in from whatever intake assessments and psychosocial assessments are already in there. Don't worry about that. Allergies will pull in the most recent vital signs. Did we have to administer anything before we transferred them? No, right? But sometimes we have to give somebody some Ativan before they leave, or maybe they had a seizure, so we gave Ativan. In this case, my patient fell. I'm going to say no. Most recent vital signs, if we took them, you can get, you know, you can plug those in here. If you, you know, actual, I'm going to say that we took them and it was, you know, perfect because this patient is fine. And just plug some stuff in really quick. Oh, that's not right. Okay, and he uses a walker, right? That's why he fell. Any emergency services, special evaluation that's required. You know what? We want to go ahead and make sure we get a CAT scan and an MRI, right? Emergency we need. So we can put, you know, provider ordered CAT scan. Apologies. And then mode of transportation, was it 911 or non-emergent ambulance? Okay. And then what we're sending the MAR, we're sending any labs, face sheet, H&P, you know, whichever of these that we have. This is the consent to transfer. So our patients should be signing this saying that we consent, they consent for us to send them, and that they consent for the ERs to give us information. Okay, so this is where we're missing a lot of stuff. So you can put e-sign consent for signature. Oh. So we're going to sign it. You can turn the tablet around and have the patient again scribble their name on here, or you could put, you know, refuse to sign, or they give us verbal consent, and write their name. Patient's name is, you know, Mr. Han. He gave us verbal consent. Okay, the patient am consenting to go. Again, same person. We need to make sure that they either refuse or consent, And then down here, your witness, and then e-sign would be myself as the nurse. So I'm missing something. Oh, I want the diagnosis. You shouldn't have to do this. Because it should already be in here. So you don't have to worry about this piece. It should already be in there from us doing our treatment plans on admission. So I e-sign, and that's it. So now my note is in there. So next shift comes on, what time did the patient leave? Where did they go? Did they give report? We have all that here, okay? The other thing that I need you guys to do when we send someone to the ER is let us know when they come back, right? So you can add it to your nursing note. And let me get down to your nursing section. So you could do it under just a daily note, say that they have come back. At the bottom of your regular note, patient came back this shift, or he didn't come back this shift, and so a day shift will have to do the note, or night shift. Or you can just do a narrative note. So if you select nursing narrative note, hit add, there's a small blurb right here. Patient returned, no new orders, CT scan, negative. Easy peasy, you don't have to do a whole lot. Just we need to know what happened when the patient came back. We need to make sure we're closing the loop on our patients. We send a ton of patients out and we have very little information about what they're coming back for. So please make sure you're adding your note. I'm going to go ahead and sign it. Again, I apologize because this is being silly because it's not letting me, let's see if I can just do test actually. All right. So it's there for testing, and I'm going to hit save because it's not letting me put my name in, which is fine. So making sure that we're doing that, okay? The other part, which you guys have already mastered, is notes. If you hit notes and then update, you can put suspend safety routes for up to 12 hours because the patient's at the ER. Please make sure you remember to uncheck that when they get back. But overall, I think you guys are doing really good with that. We just need to make sure we're doing the notes. In addition to that, if your patient is going out to the hospital, please make sure you're putting an order in for them to follow up with medical the next day. Okay, we're not really doing that. And again, we just want to close the loop. We want to make sure that we're giving the best care we can. And we're trying to change the narrative. We're trying to change the culture and change how Vidgeview feels. So please make sure. So add order, make sure you pick consults, and then scroll down to medical consult. Okay, and it's going to be once a day until complete, because I don't know if they're coming tomorrow or not, and we want to make sure they get this done. And the reason is going to be management of medical condition. Maybe I'll put recent ER visit follow-up. I know it seems like a lot more, but you guys don't know how much this saves us in the long run. Okay, we want to make sure we can speak to what our patients are doing. We want to provide really good care. And I know it's a lot, but it takes 5-10 minutes. Press OK, boom, it's gone. Now medical knows that they need to come and see him. Okay, so that's ER send outs, and then how to do the note when they come back. The next thing I'm going to go through, and again, I apologize, I know it's a lot, is making sure we're doing falls on our patient. If a patient falls and you have an incident report, this patient fell, we sent him to the ER. So now I'm going to do my post-fall nursing progress note. You can put in here that your patient went to the ER. You can put in here that the patient came back. It just needs to be documented. If there is a fall, there is a nursing note for falls specifically. And it is the same thing as basically an incident report and a full head to toe kind of assessment. So it is today, my patient fell, patient was attempting to get up from wheelchair in the day room. What was he, and fell to floor unassisted. We can put, we were unsure if he hit his head. What was the patient doing at the time of fall? Getting up. Getting up from wheelchair. Contributing factors, I mean, nothing really, maybe medication and proper use of the device because he's in the wheelchair. He could have asked us for some help. Are there any medications that we maybe gave before fall? Maybe you just gave the patient a medicine, an IM, anti-agitation, who knows? You pick if it applies, if it doesn't, it doesn't. Any injuries, okay? So here we do want to document, you know, he fell and I think there might be a slight contusion to their face. So I'm going to go ahead and save that because now he has something. Describe what you see. Contusion to left side of head, no bleeding, red spot. However you want to do it. I don't expect you guys to write a giant book or anything like that, but as a descriptive. This has really helped us. So as you guys know, all the falls are reported. And we're heading into, we've had surveys, we're heading into more surveys. We get a lot of surveys related to patients going to the ER because they want to know, did we do everything we needed to do for them while they were here? Was there something else that we could have done? And 9 times out of 10, there's something else that we could have done. Or if, you know, we always think, God, if they had just done that one little note, it would have been fine. It would have been fine. We saved the patient, no issues. You know, and then also you guys are doing this already. You guys are doing this already. When you're on the units and people are fighting and they're getting hurt, patients are falling, you're already able to speak to this. We just need it documented in the chart. So injury, you know, we already said redness. Any other comments, any interventions you did? I just picked today, or not sure why it wants a different date than it is, but so date and time, currently patients saying, you know, maybe a little bit of pain. Again, we want to copy our last that I just put in there. Any first aid given? Yes. You know, we watched, range of motion was good. Wing tremulous, no. First aid, watched the area. Did vital signs. Pain management, maybe we went ahead and gave them some Tylenol before they left. And then was an x-ray ordered? Sure, maybe the doctor ordered an x-ray instead of going to the ER. Great, so document that here. Fall plan initiated. The answer should be yes. Was pharmacy notified? No. And then if it's a head injury, did they hit their head? We don't know. You know, we're doing neuro checks every 4 hours, so they're responsive to verbal commands, no headache. And then this here is important, making sure we notify. So you're already doing this when you're filling out your incident report for your falls. This is just putting it in the chart as additional information. And to show, if anybody ever asked for this chart, that we did what they asked us to do, that we did the bare minimum on this patient. Incident reports are not usually discoverable, so you have to do it here. Was a physician notified? Yes, I'm going to say test, psychiatrist, you know, whoever that was, supervisor. Sure, I'm going to say, you know, Miss Felicia happened to be the one here today. So I let her know. And Shalette, I did the incident report, so Miss Shalette is going to find out about it, right? If in case I called the AOC. And then, of course, your dates and times, which if you type T, it'll say today. Just a little hack, so you don't have to actually type it. Type in T, the letter T, and it'll put that in for you. And then I'm gonna go ahead and sign my note, which it's not letting me sign because of my user. So I'm just gonna route it to some imaginary person. But you save your note, save it, and now everything is done, and you've done a good note on the patient for who had a fall. Okay, so please make sure you're doing those on our, especially our geriatrics who fall and we're always worried that they might have broken something, making sure we're doing those. The next thing I'm going to go through, and I promise you I'm almost done, is and I think we might have already talked about on one of the video, is seclusion and restraint. Again, no paper. Paper's bad, paper's ugly, paper's gross and ghetto. We're moving towards computer, electronic, 2024, here we come. So let's make sure we do it right. So under ancillary orders, add favorite. We've already made all these favorites, which I will be doing one on CEWA because I had a couple nurses that were confused about the CEWA protocol. So we're going to do one of those videos later. But for right now, you have all these right here. So you don't need to search for anything. Restrictive intervention is the third to last one. I'm gonna select it. It already selects everything I need to do. You remember we had it on paper and it was like 6 pages. It's all right here. Add checked orders to the patient. Come back. What did we do? Did we do a hold? Did we do a seclusion? Did they go in full-blown restraints? It will not let you pick both. So pick the most restrictive. We did seclusion, but he's in restraints, so restraints is more restrictive, okay? And the restraint indication, you know, through a chair, at the desk, maybe hit a peer, you know, whatever the case may be. And then we want to make sure all of these are going to say every 2 hours. Yeah, everything's ordered for every 2 hours until complete. So once that's done, it's all in there. If I go to my MAR, just like you do your admission, everything ends up populating right here. Okay, so the MHT flow sheet, your MHT will be able to see it on their rounds. So when you check on your rounds, there is an option to put that they are in seclusion or restraint. When that is checked, an additional like 4 or 5 questions pop up asking about hydration, using the bathroom, food, and what the patient is doing. Okay, so your MHT needs to make sure that they're checking seclusion and restraint if the patient's seclusion restraint, and then doing the flow sheet. Okay, the next thing that comes up, nursing restraint seclusion flow sheet. Click on here. And this is going through, what was the intervention? Seclusion, he was agitated, combative, threatening, agitated, threatening to harm others. His skin's intact. Nutrition, he is refusing nutrition. He's, you know, let's say he refused the bathroom. What interventions did we offer? We already do this. We try to talk to him. We offer medication. We offer distraction. Position of the restrictive intervention. If you're using mechanical restraints, they are laying down, okay, on their back. Vital signs refused. Yes. RN outcome at this point. Are we continuing or discontinuing? We are going to go ahead and continue the. Oh, sorry. Oh, vital signs refused. No, you put your vital signs in. Yes, you won't have to do that. Anything administered, please see the MAR. Currently, you know, we're making sure we're keeping them safe. And then I'm going to sign that I did this. And again, because I don't exist in the system, using that, goodness, I'm going to route to that nurse and then save it. And that is done. I have done my every 2 hours while my patient is in seclusion check. 1 hour face-to-face evaluation. They've been in there for an hour. So now I'm going to go in and I'm going to say, what are they doing? Do they still need to be there, or do we need to go ahead and take them out now after an hour? They still need to be in there. Fine. Then we're going to do that 2 hour one. Okay. So cancel. Are you sure? Yes. I'm going to hit cancel. And then this is the initial one. So I showed you the wrong one, but this is the restraint seclusion initial assessment. Go ahead and get that checked off. And this is what we're manual restraints. It's an adult for up to 2 hours. It's going to be today. I called the physician today. Time released. I'm going to have to partially save this and come back because I don't know what time he's going to get out. Alternative restrictions. We tried all this, right? We talked to them. We try, you know, any response. They were not effective. What is continuing? Staff assault. He assaulted patients. Did we search them? Or took their shoes off, make sure they didn't have anything when we put them in seclusion. Currently, no evidence of any sort of discomfort. Any medications that we gave them, your anti-agitation protocols go here. They were informed when you're calm and collected, we can let you out into the milieu, right? And then we're going to notify everybody that needs to know. Who did you let know? So let's say Stephanie is the AOC this week. So I'm going to say Stephanie Staples. I let her know. I called her as soon as it happened. And then criteria for discontinuing when they're calm. Agrees. Absence of threats against himself or anybody else. Absence of aggression behaviors. And then you sign your note. So I'm going to. Okay, so test nurse. And then I'm going to partially save it because I can't save it yet because I don't know when my patient's coming out. Now, when your patient comes out, you can go right back into it and go ahead and press save. And then restraints addendum. This is this is a treatment plan. We have to have one done. So do we need to add anything dangerous to others? Okay. We already knew that he was already there. So we, maybe need to add that he was aggressive. Dangerous to others, assaultive behaviors, because this one's just dangerous to others. And so we go ahead and add high risk. So high risk related to his NS by aggression, hitting staff. And then hit save. And you're done. And so again, you just go through all of them as we get them done. The flow sheet, it will pop up again in 2 hours after it's verified, unless the order has been discontinued and is no longer in seclusion. Seclusion restraint debriefing. So that is after everything has happened and we're letting the patient out, right? We did debrief with the patient. So the thing that happens with the seclusion restraint paperwork, if you can see, it's all for the same time, okay? I know it makes it really tricky, and we're trying to get it to where it's not all at the same time and the orders don't come in, or maybe they come in as PRN instead of standard when you put the order in, because this patient debriefing, it's not due until after the patient comes out of seclusion, and within 8 hours of them being in seclusion is when we have to do a debriefing. But it shows up here. So if you do a debriefing now, well, you can't really debrief with the patient because they are still in seclusion. So it's not wholly accurate. So that's the only bad part about being on the computer, is all standard up to one time. But right now, let's do the paperwork on the computer and we'll figure out the little glitches as we go on. 1 hour face-to-face. So after an hour, so really, this is due later, an hour from now. I would change this to 19, 17, 16. What's your patient doing? Are they still in there? What time did you put them in? What time are you doing the face-to-face? Are they going to get released? If not, again, partial saving, you have to come back to it. And then what is the patient doing? Are they free and ready to come out? System review, are they okay? Any information that we need to know about? Are they meeting the criteria for release? And then communication again at the end. So this is your 1 hour assessment of the patient. Okay, so a little bit more tedious. Knock on wood, we don't have very many seclusion and restraints as much as we would think we do, but it does need to be done in HCS, the entire thing. On top of that, you have to make sure that we're putting the order in. So this only gives you the initial seclusion and restraint initial assessments, as well as the treatment plans and the face-to-face. It doesn't give you the order. So under ancillary orders, we will have to write, if you come down to restrictive interventions, which one are we putting down, right? And so you want to pick your restraint or seclusion. I wish it would all come in together, but though the initial one is just for the assessments and it doesn't put an order in. I will see if we can put these together so that it's a little bit easier, but when I asked a couple weeks ago, it was difficult. So making sure we put in a restraint, it's going to be a mechanical restraint for aggression, hitting people, and then hit okay. And now here it is. So now all of this is my restrictive. So I have my flow sheets, I have my face-to-face, I have my debriefing, I have the actual restraints. Oh, it's on there twice, I apologize. So I have my actual restraint orders and then the whole assessment. So what we've been seeing is we'll get a restraint order by itself, but without the assessments, or we'll get the assessments without the order. Okay, so please make sure that you're putting in an actual order and then completing all the paperwork timely. Which brings me to my last part, and I know this is longer and I'm starting to ramble, making sure that you're going to your nursing status board and there should be no red. That's it. There should be no red. There should be no red. There should be no any other color. It should all be taken care of. If it's red, because it'll say admins, med admins are overdue or task is overdue. That means we didn't do something. So we need to make sure we clear the board. You should be checking this several times throughout your shift. You should be clearing it before you leave. It should not be red. I know a lot of them are already red. I'm going to go through and I'm going to see what I can clear out. And it's still in simple stuff. Vital signs aren't being logged in. If your MHT took vital signs, please make sure you're signing them off on your MAR. Okay. The other big one is patient needs doc response, documented response. When you are medicating your patient, I know, and I will go ahead and pull one really quick just so you can see what it looks like. But I know for a fact that when you're pulling in, I'm sorry. Here we go. Okay, this one has one. So when you're pulling in and you're passing out medications, this is red, right? We can't have any red. We want to make sure all that is taken care of. It's a lot of red, but this is a dummy patient. But you also want to make sure that you're following up with your, and it's probably really far back. If you give a medication, it'll say, I'm sorry, it'll say in purple, document response. Was it effective or not effective? So a lot of times I'll log in and I'll see a lot of purple and I'm like, that's an easy fix. Needs documented response. You just click, you gave the med, an hour later it's gonna say, hey, did that med work? Click on it, hit effective, save, and it's done. And then you won't have anything. So that's what shows up under this one. Patient has meds that are coming up due. That's, you know, in the morning at 7 a.m. We know we have 9 a.m. meds, not really a big deal. This one's come up a couple times, med order that needs to be verified. When a provider writes a new order, ancillary or medication, it needs to be verified before it can be active. So this is how you find out if your doctor wrote a new order. Okay. And so this is getting missed. We missed a blood draw and we missed a change in medication for a couple of days on the units recently, and it's because no one ever verified the order, which means no one ever looked to see, right? This is your chart check, right? We used to do chart checks twice a shift. At the end of the shift, make sure we didn't miss anything. That's what this is. So please make sure at the end of the shift, or maybe an hour or two before it ends, that you click this med that needs to be verified, and then I click on your patient and you go to see, well, which one hasn't been verified? Oh, I never verified this one. Okay. Got it. Now it's verified. So the patient can get the medication, next nurse can do it, or you can carry out whatever it asks for. If it's saying, this one right here, we need a TB solution. You didn't know that they ordered it. Now you do. So please make sure, this is like your chart check that we did on paper. Make sure you're doing your needs to be verified. Same thing with ancillary orders to be verified. So you have their 2 buckets. You can pick, what do we need to verify to make sure that we're not missing anything. And it's simple stuff. Okay. Got it. We don't have to worry about it. As soon as it's done, you'll see that it is refreshed, it's taken off your board. Okay. Observation rounds. You guys are doing really good about making sure we do these. Home med list not complete, hit or miss. Admission med rec not complete. This is the one that I look at every day and go in and try to fix. Please make sure you're doing this upon admission. If you have more questions, I did a video about this in September. You can check that one out and see. And then, of course, all consents not obtained. That's hit or miss because sometimes we just don't have consent for them. So the big ones you want to make sure you're checking are your needs to be verified, and then making sure that your admission med recs have been completed. You should be doing those upon admission. Okay. So I know this was a lot in this video. So I apologize. I was trying to go as quickly as possible. So this was already way longer than I wanted it to be, but just a couple of things that have been popping up as we've, been playing within the system for the past couple months. In general, to be honest, I see a great improvement. There's always room for improvement. Not a big deal. We're going to get there. But please just make sure that you are doing the admissions all the way, that you're signing everything. Check your work list. I said this earlier. Check your work list to make sure that you don't have anything pending. Right here, pretty easy. Let me show you. Make sure you're checking. I know I've been to a couple units. This notification right there is your work list. Okay, so the exclamation point is your work list. This was a fake profile, so I don't have anything to sign, but a lot of nurses have a lot of things they need to sign. Please make sure you tackle that when you're at work next time, because we can't close those charts out for medical records if it's pending signatures. Okay, so that delays just everything. So please make sure you're signing stuff. Plus it makes it look like we're not doing stuff, right? I can say, yeah, the nursing assessment was done within 8 hours as Joint Commission requirements dictate, but you forgot to sign it. So technically it's not done, even though the whole thing's done. The whole thing's done. You even wrote a really great little blurb on there. It tells me everything. It has everything. It's great nursing admission, but you didn't sign it because you partially saved it because something happened and then you didn't get back to it. That's considered that it wasn't done. So please make sure you're checking your work list and that you are signing things in real time. I would say check this definitely before you leave. Maybe when you first get on, it opens to this automatically. And I know a couple of nurses who were with me when we did it, and they're just like, oh, I just ignore that. Don't ignore it. Sign it. That's all I have, guys. That's the last of the the guides for HCS. If anything else comes up, you have questions, please, again, as I've said, I'm always here. Table of contents, you can find anything you can possibly think of. It's in here. We've made different tabs. We've added stuff. A lot of the times, if you just start typing a little bit of what you think you're looking for, it'll pop up right there, okay? All right, guys, thank you so much for everything.